we speak about eye screening of children and dancing through the Nepalese school, please.
Good morning, everybody. I know we're all a little tired and sleepy, so let's just push through. So, the title is Eye Screening of Children and Adults at Rural Nepalese Schools by me. So, I belong to an organization called We Inc., or as we like to say, Wink. And it's a Tokyo-based startup providing affordable and accessible eye care, primarily through the device Smart Eye Camera. Now, I'll describe that later, but our mission is to reduce worldwide blindness by 50% and save people's health through their eyes. And the founder is actually an ophthalmologist, a dry eye specialist himself from the prestigious Keio University, and he's my supervisor. He's here as well. And we have an extremely international team, 11 languages available, and backgrounds of medicine, business, law, linguistics, HR, and many more. So, what was the Nepal Eye Screening Project? It was actually a combination of eye screening and dental screening across multiple schools in some villages. We worked with a local organization. It's called, you can see there, the Buddhiman Eye Care Foundation. And we also had some of their other local members join us. So, our objective was to look at the prevalence of visual disorders and assess the need for eye care in those areas, because there are not any papers published from that area, not a single piece of information available. And Nepal has about 400 ophthalmologists, and the population is 30 million. Most of the ophthalmologists, just like in most countries, are focused in big cities. So there is a big gap. And it's actually pretty hard to get to that village because we land in Kathmandu, and after landing in Kathmandu, you take a flight to Pokhara. That's okay, that's easy. After that, it's a 3 to 5 hour car ride, very bumpy, very rugged, easily one of my worst car rides. And where we were, it was a very rural area, so we also had a lot of blackouts. A lot of times, no electricity. And the location is written on the bottom. I'm not going to read it right now, it's very long. So, very simple. We had stations for visual acuity, and then we had a station with direct ophthalmoscope, and we had another station for sort of paperwork and consultation, and we had a table for us, We Inc., where we had our portable slit lamp microscope. And we did, cover-on-cover tests. We also did the slit lamp microscopy, of course. And we had the Welsh Allen spot vision screener. And we had an eye care, which unfortunately didn't perform well. Couldn't quite use it, so had to get rid of the eye care. And so, in these schools, we divided the population into 4 groups, as you can see. And throughout my analysis, I would compare the first 2 to the latter 2. And from my discussions, what I have found out is that, here I've written it a lot, so I don't want to read it too much, but I'll go through it. So for spherical equivalent, we found out that there's a high p-value for the correlation test, right? Between the first 2 and the second 2 groups. And that means, sure, our hypothesis is in the right direction, but age alone cannot serve as predictive value of myopia in this population. Which makes sense, right? There's a lot of other factors other than just age. And then for visual acuity, unfortunately our p-values were also very high. And what we found out, or at least what we assume, is that the visual acuity it's not having as much of an effect because myopia rates are actually very low, right? These are rural kids, they're not iPad kids. And for eye positions, we did find a very direct relationship that with, increasing age, there is a deviation in eye position and higher chances of gaze. And we also had 1 case of nystagmus for a 14-year-old female, and we had 3 cases of bilateral cataract. of teenagers. So this was taken through the Smart Eye camera, the portable slit lamp microscope. And yeah, these 3 kids were later taken care of by the local organization. And we did hear back from them. I'll let you know that in the conclusion. Okay, I guess here we are. And so, because of the logistical challenges and geographical barriers, there is an extreme lack of eye care and access to resources. And, power outages don't help. Other than that, data collection was also barred in many ways because of these power outages. So we went back to doing analog data collection, just writing things by hand. And beyond that, as I mentioned, there is a small prevalence of cataracts among younger people, and this alone shows that we need to have more such screening camps. Because 400 kids and you have 3 cases of bilateral cataracts, it's already a lot. So we must continue doing this for the local communities there. And Smart Eye camera, along with the other portable tools, were extremely important. And what we're also trying to do is to see if we can do bigger studies to, further get more clearer data. And as far as those cataract children, unfortunately, because they're still functional, right? They are going to school. That's where we found them. There doesn't seem to be an urgency from them or their family to take care of this. And we can't completely blame them either, because it takes a very, very long time to get to the city. It's extremely hard. It was an irritating journey for me, let alone, for them, where they wouldn't have access to the resources that I had, and not to mention the finances. So, unfortunately, that's where we are. But that is also something to think about, and that's something, we will try to incorporate in our next study, because this is just for diagnosis, right? This is you figure out what's wrong with them, but what do we do next? So that's something for us to see. So I would quickly just like to explain what is the Smart Eye camera, right? It is essentially a smartphone attachment, and it can substitute in many ways a regular slit lamp microscope. So this is a regular smartphone, right? Smart iPhone 8, cool. Now, here the flashlight is on. I put this here, like this. Oops, sorry. Oops, that's it. And here we go. It's a little bit light here, so it might not be able to see, but yeah. So this is for the front of the eye. Of course, this looks at the anterior segment. We have the other 2 models for the posterior segment as well. And if you have the anterior segment model and one of the posterior segment models, you're good to go. Right? You can perform your eye checkups. And I just explained the hardware. And the beauty of it is that it uses the camera and the flashlight of the phone. So you don't need any external peripherals besides the attachment itself. And we also have a dedicated software for case filing, like you would have in any regular clinic for video filing, and you can access it later. And we also have telemedicine functionality. So I can take a video here, right? I'm doing research in eye, but I'm not an eye specialist. But if I take a video, I can ask my supervisor, who might be somewhere else, and provide feedback through the chat function. So this is actually something, it's a function we use in Japan a lot because there are a lot of rural islands. And those rural islands don't have specialists, including eye specialists. They have primary care physicians, they have nurses, they have med students, volunteers, but they do not have eye specialists, usually. So over there, we have given them the devices, and a doctor on mainland provides them feedback. And this way, we've been able to diagnose various cases for a lot of the elderly population, which is huge in Japan, and also economically, unfortunately, just increasing in the world. And follow-ups were also performed in that manner. And we also have an AI system building right now. It can already detect and grade cataracts. And because we use videos, not one image, it has multiple frames to look over. And my supervisor actually has a presentation on it at 3:10 p.m. So if you're interested, please join us. And I just explained about the telemedicine. It's very easy. You just follow these steps, and in the chat function, you'll be told what to do. and this is for the AI, is just one button for cataract grading, and we also have anterior chamber depth measurement, and we have anemia coming up very soon. And I already described, along with the anterior segment model, we have the posterior segment models, and just to kind of make it clear, the same features of case filing, video recording, telemedicine, and AI do apply. And the importance of Smart Eye camera, what we found out is, of course, in developing areas, it's very simple, right? Like, they don't have access to big, bulky equipment. We're there with the portable equipment. Great, right? There's telemedicine, there's AI. But also, with the AI, it can serve as first opinion in many places where they don't have eye specialists, or they might not have internet and therefore no access to telemedicine, right? And in developed areas is the portability. So I myself, and along with my colleague, we go to the homes for the elderly and the homes for the disabled, where people are bedridden, they can't move. So this is a great use there. Not to mention, the AI can serve as a second opinion in these cases as well. And of course, we use it in research and education. So we have a pretty global track, and we pride ourselves on evidence-based medicine. We have active partners in over 60 countries, including Vietnam, of course. We've actually just recently had a paper published, and on top of that, we have more coming along in the next 3 years from 35 more countries. And we are registered in all these locations, including Vietnam as well, which makes all the paperwork and everything much easier. And if there are any questions, I will take it. Otherwise, thank you very much. No questions? Great.
Xin cảm ơn bác sĩ Rohan Kenbabi. Chúng ta bắt đầu cái phiên cuối nó hơi muộn. Tuy nhiên thì chúng ta đã có xong 4 cái bài báo cáo của 4 tác giả. Chúng tôi cũng xin được kính mời các quý vị